Real is the patient.
Yeah, it's a bit, I'm not sure whether it's a sort of abscess walled off anyway. We'll get a bit of it.
This team of medics is taking part in a training session using a simulated patient. Consultant anaesthetist Frances Forrest is in the hot seat, playing the role of the student. She's got to work out what's wrong with her patient.
At
the moment we're running a standard child with normal physiology, and we're subjecting that physiological model to an anaphylactic shock. And we hope that the person that's being put through their paces out there will pick up that an anaphylactic reaction is going on.
From the control room, the simulation centre manager can throw any medical disaster in the handbook at the dummy and then sit back and watch how the team handle it.
Frances is the student being put through her paces, and she's coping quite well at the moment, as you can see, and she's picked up on the wheezing in the chest, which has probably indicated to her that we may have an anaphylactic reaction, possibly due to the drugs given or possibly due to the latex gloves being worn by the surgeons.
And we can always pause for a second.
Yes, I could pause for a second while I just sort this out. One of the problems that you have is having to trust that the machine is as real as a patient, and some of the clinical signs are not quite as crisp as they would be in the real scenarios, so it can take longer to get to the right diagnosis.
The simulated patient was developed at the University of Florida, but is now being used by training hospitals all over the world.
If you can think of a situation that's happened to you in the theatre, then you could recreate it. But we tend to pick situations medically known to happen, like for instance anaphylaxis or malignant hyperpyrexia, and then we recreate them using an editor within the software.
The training session is recorded so that medical students can learn from their mistakes at a debriefing after the operation.
What's happened? Oh, my throat's sore.
The controller adds extra realism by speaking for the patient. The voice comes out of the dummy's pillow.
All right, sweetheart.
Where are I?
You're in there waking up from your operation. We're taking that appendix out for you.
Bit of oxygen for you to breathe for a minute or two.
That's it. Well done, William.
The patient seems to have survived his ordeal.
The worst case scenario is that he could die, which is, of course, is not a very nice experience for the trainee if the patient dies.
Told us what operation we do.
There are a lot of things that are very, very real about it. The environment that we're working in is based on a real operating theatre. Some of the things that we would see when things are going wrong in clinical practice, like temperature and colour, are absent from the simulator and can confuse the issue a bit, so you have to ask the questions in a different way. So there's probably a learning curve for those of us going through the scenarios as much as those people sort of teaching with them.
At the moment you can see he's awake, so his eyes are open and blinking, and he's got pupils which actually react to light. So if I shine a light in his eyes, then his pupils will get smaller and get larger as they're exposed to the light. And so that's really quite a useful sign of awareness. And of course when he goes off to sleep, then his eyes will shut and he'll become unresponsive to anything that we say to him. So that we can allow the people using the simulator to give drugs directly, there's a barcode reader here which allows us to use barcoded syringes which identify the drug with a label on the front. In this case this is adrenaline, 100 micrograms per mil. And all the drugs that we use are in fact water drawn up from a large bag on the side. But it means that when we actually place the drug on the barcode reader, we can inject the drug, and as soon as the stopcock is turned, we get an immediate effect in terms of the drug being administered. The effect of the adrenaline has been to induce a very rapid tachycardia on the monitor screen, and I can feel the pulses cracking along at about 200 now, which is significantly faster than it was a moment before. It's all being analysed by this long umbilical cord that connects him to the computer stack here. And within this, there's a series of bellows which allow gases to be mixed to mimic the normal expired gas from a normal human being.
This is the first time in anaesthesia that we've got an opportunity, a bit like pilots facing engine failure on takeoff, that we can look at the problems of failed intubation, problems when patients wake up and they can't breathe properly, and how you deal with them. And that's particularly good for very new trainees who are about to go solo giving anaesthetics, and we need to check that they're good enough to go solo.